Good morning, and thank you, Georgina, thank you, Tanya, and Fiona, to Robert for the invitation and the opportunity to share the work we're doing in Mexico. The first thing you may notice, I changed the title. I didn't want to be provocative, but definitely, I only represent thousands of or hundreds of people working at the field, between doctors, nutritionists, nurses, administrators, people in technology that enable to deliver the care that we're doing right now. And also, this is a very special presentation to me because I was part of Angelis G Lab, and so I work as part of her course. I went to South Africa and worked for an HIV company, and I learned a lot about managing chronic diseases and a lot of technology around that. I was at Fiona's class as well in how to take strategies for technology for new enterprises. And that was very important because one of the challenges is how you take the ideas from the lab or the classroom to the field. And even today that now we treat thousands of patients every day, and even it's very hard to innovate now within the company because if I want to make a change, how do you change 300 people or doctors and that are doing their work every day the same way because it's very standardized. So even the challenge right now to do that. Then of course, I was a Legatum Fellow, and very, very important to where we are today. In fact, when I was preparing for this presentation, I went and looked and found the final poster that I did for the Legatum Fellowship. And it wasn't that bad, actually. And of course, I wanted to have 30 clinics by the second year, and that was off, very, very off set. And but it was a pretty good, very good fellowship. Allowed me to reflect and what was the need and how we're gonna tackle and innovate around diabetes care. Very briefly about my story, and I wanted to be an astronaut, and since I was a child, and it was my passion, the space, telescopes, and technology, and for some of us, reading the popular science, popular mechanics magazines, and so that was one of my passions. So MIT was always my dream, and so when I was applying for undergrad, I wanted to be this Mexican scientist that was going to change the world, but I realized that I didn't know Mexico very well. So I decided to go and live in indigenous communities in Mexico, on the Sierra Tarahumara. I lived there for almost a year and a half. Then I started a nonprofit and run it for 10 years. And I did a lot of projects around nutrition and education. And what I learned there is that if you want to do good, it has to be an innovation. It's not only to get to these communities and say they need to get better, they need to have better access, they need to have better healthcare. That must be an innovation. So I get a passion of how technology improves access or technology improves quality for people. And then I went back to Monterrey, Mexico, where I'm from. I did study physics engineer and worked for 8 years at a very large corporation as a continuous improvement manager. So always around this idea. I was running the nonprofit at the same time that I was working at the corporation. And then I got back my dream of going to MIT. So luckily I was accepted for the MBA, but with a lot of focus on how innovation and entrepreneurship and that I could take back to Mexico. And so I did the entrepreneurship and innovation track. And but also I took a lot of my classes at the Harvard School of Public Health, and especially around technologies for healthcare, and I did a project for the Minister of Health of Tanzania in how to diagnose diabetic foot for the island of Pemba and Zanzibar. Also, I worked with the Harvard Banker Group on how technologies help people with diabetes, and I was fortunate enough that Dr. Julio Frank, that at that time was the dean of the school, was the former Minister of Health of Mexico. So I got a great opportunity to work with him and understand much better and the needs of the diabetes care. But when I was doing all this research and looking at this state-of-the-art technologies, it was the first time that I called my mom back home and ask her about her diabetes. Just to find out, as we know, that she was very lonely, she was exhausted, going from one doctor to another. She also had breast cancer before, so she will go to the endocrinologist and then to the oncologist, and at some point, she just shared with me that she was completely exhausted, that she didn't want to get care anymore, even if she will die from it. So that was kind of like shocking to me, and say, well, what can I do for her? And then if she's going through that, even that she had a private insurance, what's happening with the rest of the population? And that was when I got the idea of building Clinicas del Azucar. It's a one-stop shop to provide affordable, specialized, and convenient diabetes care in Mexico. It will sound ironically, but as a technologist, I love retail, I love process improvement. So a little bit ironic, but I was thinking why we don't have the McDonald's for diabetes care? Why have to be so complex to go to the doctor, nutritionist, the lab, diagnostics, and it's so easy to go and grab a hamburger. So if we can do as easy as getting a hamburger to get diabetes care, that's when we're gonna get the things right. So just very briefly, in Mexico, diabetes is a catastrophe, and there are more than 14 million people with diabetes and growing, unfortunately, and it's the #1 cause of death. 100,000 people die every year because of the disease. It's the #1 cause of blindness. It's the #1 cause of amputations. It's the #1 cause of failure. And even in the state of Nuevo León, where I'm from, is the #1 cause of suicides. Almost 30% of the people that try to commit suicide have to be between the fear of complications, because they saw that some of their family relatives get an amputation, so they said, if I'm not getting care, I'm gonna get the amputation, so why should I live for? We are now, it's been 8-9 years since we start. We are now the largest private provider of diabetes care, and it's a one-stop shop, and mainly, I will speak a little bit about the business model or the care model, but we put doctors, nutritionists, the lab tests, diagnostics in the same roof. And we leverage a lot of behavioral science, and I was very excited to be here because I know how important behavioral science is here at King's College. And so we leverage behavioral science and data and process improvement to help patients. And we have done a great result in reducing the time that the patient spends at the clinic and also the cost. And we charge so we have different prices based on different services, but it could cost from 30% to what actually people will have to pay outside the clinic. And also, we are achieving great outcomes. Even right now, we're running with Professor John Gruber from MIT, Professor of Economics. We're running an RCT to measure the impact on outcomes and health expenditures of our patients. And we are achieving a very good A1C control versus the top clinics. And this number, I know UK has 65, almost 70%, but this number, you have to imagine, this is garbage pickers, this is people that have very small shops at the street market. It's out of pocket. They pay for care, they pay for their medication, and we're achieving these results. So the care model, it's a one-stop shop. It's like an assembly line. So the patient comes to the clinic and spends 10 minutes per station. There is a lot of technology, a lot of very robust software on the background. And it's a subscription model, very innovative. We charge an annual fixed fee. They can subscribe by month or by year, and everything is included. It's unlimited. And of course, there is a lot of operation analysis and financial simulations, because it's like a club. And this is what very important, because what we learn, it's for very low-income people, there's a lot of fear to go into the doctor because they never know how much it's going to cost. And and their cash flow, disposable income is very stable. They usually have $100 a month. So if they go to the doctor and it's $10, it's fine, but if it's $50, it's completely out of the reach. So that's a lot of the fear that people don't want to go and get care. So giving certainty to the people as how much they're going to pay, and that's all included, it was very important for them. The other two, we capture a very high volume of data, more than 2,000 variables per patient, all in an electronic health record. And it's a unique database because it's integrated. We have from what the doctors prescribe, what the nutritionists recommend, to the A1C, lipids, and microalbuminum results. So we have a huge opportunity to personalize and to optimize resources. And of course, very good ability to remote clinics online to ensure the quality and the impact. And what's it's a very a lot of satisfaction for us is that the blue bars is a typical private care in Mexico. And also just to for people that are not aware, in Mexico we all have access. If you work for a company, you have access to certain government clinics. If you don't have a formal job, you have another type of like insurance. But just imagine the IMSS is when you work for a formal company. They have 60 million people on the network, and there's, I think it's like 10,000 hospitals, clinics, and is the largest employer in the country. So very difficult from rural areas to cities. So it's not that they don't want to do a good job. I mean, they are great government officials, they are great doctors, they are great administrators, but it's so difficult to manage this large amount of people and the quality. So typically 50% of the people still have to go to private care, and that's the blue bar, and also is the orange bar. So the opportunity that for low-income people to access private care. And the reduction in complications is because if you go to just the general physician, and it's a very simple clinic, they don't perform A1C, they don't check they do a retinal image, so most people get a complication. Only like 15% get their diabetes on control. So, and that's where the more we control and the more complications we prevent. And I was asked a little bit about what is the role of entrepreneurship, and this seems a simple and statement, but I think it states what's happening between the academia, universities, and the field. So for me, entrepreneurship is your past life experience allows you to discover an opportunity, but also your current and future life factors motivate you to take action. So there are so many people that I jump into schools in Mexico and they had the same idea. And probably if I ask for one of ideas, we all do have very similar ideas. And those are important. So entrepreneurship take a role either creating the idea or taking action to implement that. And that's where we complement between the field, between governments, between universities. It's sometimes the idea is created here, sometimes the idea even is taken from here to the field because of some factors like, in my case, and seeing my mother, what she was feeling and she was going through, and motivate me to take action. And what's the future for us? So it's to reach 200 clinics in Mexico in the next 3 to 5 years. And we just create, in partnership with Deloitte, the Diabetes Notch Lab. And with the idea of, we had it wrong because we provide care very standardized as a one-size-fits-all. And now we realize that we all are different. So some of us are very competitive. And you might have to tell them, you are not the number one in A1C reduction. And they get so excited to be the number one. But some of us are more collaborative, and you have to tell them that you and other 5 are struggling, so you should collaborate. And we were always giving the same message to all of the patients. So now we're building archetypes and testing different interventions to reduce the cognitive load. So depending on how good you are to meet goals, for example, and so we give you different paths. So it's a way to personalize care, but not only on the medicine side, but also in what we have to tell you. And especially because the lowest income people suffer the most with this, and so we have to tailor that. And in healthcare, so I've been 4 years member of the Global Agenda Council for the World Economic Forum on the future of the health sector and the future of behavioral science. And one of my comments always there is that in healthcare, innovation increases cost. We're always looking for the best, a better machine that increases the 2%. But the future in emerging markets, it's innovation have to reduce cost in order to create access, to make people access quality care or specialized care. So I think I really admire the effort that MIT and the King's College are doing, and not only to think about how to improve the UK, that is pretty good, and in diabetes, definitely, I mean, we follow the guidelines of UK because they are more cost efficient than the ADA, the US ones. So I really admire the health system that you have here, but I admire that you're not only thinking about hey, how we improve here, but what can we share and what can we take to countries like Mexico and to improve also the care there. Thank you very much.
Thank you so much, Javier. I mean, you can see Javier is such a special member of our community, and now you can see why. Fiona mentioned the importance of creating human agents that enable change. I mean, Javier is a living example of that. So we do have a few minutes for questions now. So I'm going to throw it to the floor. And if anyone has a question, please raise your hand, and we will bring a mic straight to you. Oh, we have a question right here at the front.
First of all, congratulations, Javier. It's an amazing business to have built something so large and also so impactful. The question I had, as a venture capitalist, I look at the sort of underlying model of what you've done, and part of what you seem to have done, I think, is unbundling. You've taken something which is usually delivered in a very integrated way and said, I'm just going to focus on one thing, diabetes, and I'm going to make it, as you say, a one-stop shop for that specific problem. Do you think that's a generally interesting model for healthcare innovation? So should we be taking very, very focused approaches like you have, going after one disease or one problem at a time? I noticed in your photo of the original plan, you actually had a few other disease areas on your list, which it sounds like you never got to in the end, because I guess diabetes became a big enough opportunity. But I'd be fascinated to hear what you think about maybe you can do similar things in parallel or together.
Yeah, that's a good question. And even right now, we integrate hypertension. And we're wondering about mental health, because a lot of the patients have depression. And unfortunately, when we refer them for retinopathy, for example, we have a good network with the government. But for mental health, and it have to be too private, and many of the people struggle to that. So I was lucky enough that at the year, I took a Clayton Christensen class, and now he's been a great mentor. And I was just a couple of months ago celebrating with him the 10 years of the Clayton Christensen Institute. And so I followed the ideas of disruptive innovation, and you have to focus on to leverage human resources and be able to focus on a specific disease, because you can implement technologies. And if I will be just a general care, and I could not reduce the cost, I could not leverage technology. So yes, and it was very intended from the specific. I think, and you can take it to many other diseases. And to me, the difference between diabetes in India, diabetes in Mexico, diabetes in Colombia is who pays. And because I learned we all behave the same, we all struggle the same. And so the model have to be also tailored. And from a venture capital, it have to be tailored. And also this is a good, just to mention, some people ask me, is there a for-profit, is there a non-profit? And to me, you don't define that. The market defines that. If the cost is higher than the willingness to pay, then you have to be a for-profit and subsidize care. If the cost is lower, so we did a research of how much people would be willing to pay, and that was $250 compared to $1,000 that typically cost. And just like the Apollo movie, it's like, okay, we have $250. What can we do with it? And we look for the 80-20 in diabetes. Okay, what the 20% of the jobs to be done, as Clayton mentioned, that we have to perform to impact 80% on the A1C. And if we are able to have the cost below that, we could be a for-profit. Now, it could be a for-profit, low margin, and we have to look for more impact investors that they balance between returns and impact. And that's where we are. So we have raised money from impact investor, now the IFC, and always my comment is, I'm not a typical technology investment because it's low margin, high volume, but if we are able to scale it and we are able to grow, then we can be a very sustainable company at the same time that we have a huge impact. Thank you.
So we'll probably have time for one question, and then for those who I don't get to, please use the Hoover app, and I'll encourage Javier to answer offline. So I think we had a question here in the front.
If the government decides it wants to put more money into prevention and healthy lifestyles, what's going to happen to your business model?
I'm sorry.
If the Mexican government decides that it's interested in promoting healthy lifestyles and less diabetes in your country, what's going to happen to your business model?
Yeah, well, definitely. And I remember at the beginning, it was the first couple of years, I went to one of our doctors and I asked him, why not only with lifestyle changes and to go for instead just of medicines? And his response was that is great. Unfortunately, 90% of the population cannot meet goals. And typically when we are in these kind of forums, and we are here because we are pretty good at meeting goals. And we're very disciplined, and we have accomplished, and that gives us a lot of self-confidence to accomplish more. But when you go to the general population, they have the opposite. They have failed in so many goals that they believe that they cannot do one more. So when you tell them, let's do diet, let's do exercise, the first thing they think is, I can't. And that's why they're looking for what we say, the miracle cure. They're always looking for something that without effort, because they are so exhausted of not meeting and not being able to accomplish something. So that's why we are really looking forward to behavioral science. Because instead of telling people, okay, you have to do exercise, you have to have a better diet, we believe that you have to create nudges. You have to go all the way. And without telling them to do that, you have to nudge and help them. And as an example, we typically say, you have to do a new menu and share even your cooking oil. And people struggle in between buying medicine or a new cooking oil. And now we just said, okay, first thing, let's reduce your soda consumption. And most people drink 2 liters daily of Coca-Cola. So just imagine why there's so much diabetes. So the first thing we do, and not even you don't drink Coca-Cola, we always let's reduce half. Let's go for 1 liter. And so as people get more self-confidence, like, oh, I accomplished that, okay, let's go for a little bit more. And then you go for water, and then you increase fiber, and then you reduce cereals, and so on. So very, very good question and between treatment and also preventive care and how you deliver that.
All right, I'm afraid we're going to have to close questions for now, but again,